Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The cardiac arrest algorithm is the most important algorithm to know for adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including a first shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their arrest, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt. Treatment then branches into two pathways, one for shockable rhythms, which include VF and pulseless VT, and a pathway for non-shockable rhythms, asystole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. After 2 minutes, conduct a rhythm check. For persistent VF or pulseless VT, give another shock and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shock has been delivered. Repeat epinephrine administration every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. During resuscitation, epinephrine acts as a vasoconstrictor, which increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. After 2 minutes of CPR, conduct a rhythm check, being careful to minimize interruptions in chest compressions. If a rhythm check reveals a shockable rhythm, deliver another shock. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone or lidocaine, antiarrhythmic agents that have been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha-adrenergic and beta-adrenergic blocking properties, and it also blocks the action of hormones that speed up the heart rate. The overall effect is to slow the heart. Additionally, it lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. Lidocaine depresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. After administering amiodarone or lidocaine, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5 and work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you are unable to achieve ROSC in a reasonable amount of time, consider the appropriateness of continuing resuscitation efforts. If you encounter non-shockable rhythms at step 4 or 6 and there are no signs of ROSC, go to step 10 or 11 on the asystole PEA pathway. The asystole PEA pathway is the option when the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. If the rhythm after step 10 is shockable, go to step 5 or 7. If the rhythm is non-shockable, continue CPR for 2 more minutes and attempt to treat reversible causes if these have been determined. If there are no signs of ROSC, repeat steps 10 and 11. If ROSC is established, move on to post-cardiac arrest care algorithm. The cardiac arrest circular algorithm is another way of displaying the cardiac arrest algorithm. It summarizes the recommended sequence of actions after a cardiac arrest. It makes the point that not only is high-quality CPR performed continuously, but also CPR quality is monitored consistently.